Good afternoon. Thank you everyone for joining us and welcome to today's training, Simple Steps to Help Save Lives, Practical Suicide Prevention in Primary Care for Students and Newly Practicing Clinicians. My name is Rick Brown, and I'm the Associate Director of Communications and Membership with the Association of Clinicians for the Underserved, and I'll be your host for today's webinar. We're honored to be able to co-host today's presentation with the American Association of Teaching Health Centers and the National AHEC organization. For those of you who are new to ACU, we are a transdisciplinary membership organization uniting clinicians, advocates, and organizations in the shared mission to establish a robust and diverse workforce to help transform communities to achieve health equity for all. We do that by providing advocacy, professional education, training and technical assistance, and more to develop and support clinicians in the healthcare workforce caring for America's underserved communities. We invite you to learn more about us in membership with ACU at clinicians.org. If you're interested in more resources on suicide prevention in primary care, we also encourage you to visit our Suicide Safer Care program page, where you can find a variety of resources, including our new Quick Tips Guide for healthcare professionals in training, and our upcoming office hours webinar on suicide prevention that we'll highlight later in today's presentation. I'll also put the link into the chat, but you can also scan the QR code to go there now. Before we begin, I just wanted to also go over a few quick housekeeping items. First, if you haven't yet, we would strongly encourage you to complete our pre-survey. It's very helpful to helping us assess and improve our trainings, and I'll put the link into the chat there as well. Second, we will be recording this session, and we will send you the recording within a week of the webinar, as well as the slides. We also encourage you to ask questions via the chat during the presentation as you think of them, and we'll also have a dedicated Q&A at the end of the session. Lastly, I am honored to introduce today's speakers. Dr. Virna Little is the co-founder and special advisor for advocacy and research at Concert Health. He is also the chief operations officer and co-founder of Zero Overdose, as well as a member of ACU's advisory council. He is a national expert in suicide prevention, a faculty member for Zero Suicide, and previously served for over 2 decades as the senior vice president of a large FQHC network in New York. We are also very pleased to have with us Dr. Julian Minton, a general internist and addiction medicine physician and clinical assistant professor at the Baylor College of Medicine, a healthcare innovation leader and public health champion, committed to advocating for improved and equitable care for traditionally marginalized populations. He has collaborated with several leading healthcare organizations, including Harvard Medical School, Common Spirit Health, Concert Health, and Verily Life Sciences. We're excited to have them presenting with us today. And with that, I will turn it over to Dr. Little to kick us off.
Great. Thank you, everyone. We really appreciate the time today and looking forward to some good discussion. We're going to talk a lot about suicide safer care in primary care, and particularly what can you do to care for people at risk for suicide in care settings. So first of all, we're going to talk about suicide. Suicide is not uncommon anymore. One of the things we know is that millions of Americans, 10 million Americans, think about suicide. A lot of people think about how they might die by suicide, and many are going to attempt to die by suicide. So one of the things we know is that as you practice each day, several of the people that you care for are likely thinking about suicide and may try to die by suicide this year. As we start, I want to just set us off. Language matters. Really important. You're going to hear me say died by suicide. So often you still hear committed suicide. People commit crimes. They die by suicide. I know this is some of the most difficult language to change, but really encourage you to use died by suicide. Also, successful or unsuccessful attempt. I can't tell you how many people have been introduced to me over the years who said, here, I want you to meet so-and-so. They had an unsuccessful attempt. And so what are we really saying? You can't die by suicide successfully, or had you been successful, you wouldn't be with us. So really making sure we're watching our language. And also I get the opportunity to do chart reviews and to look in charts. And it's interesting to me in the electronic health records, often in the flag section or comment section, there'll be patient is manipulative, and it's always in big capital letters, or patient is attention seeking. And I know a couple of things. One thing I know is that if someone is talking about suicide, they're more likely to die by suicide. So I just kind of start there. The second is that I know for me, I often have to say, like, that wasn't my intent, right? I didn't intend to do that, or I didn't mean that. And so I don't pretend to know someone's intent. And so, what's most helpful to my team is to talk about or to document what someone actually said or did, as opposed to trying to pretend to know their intent to be manipulative, as an example. And to use words like caring for, as opposed to, dealing with, which oftentimes you hear. So when we think about suicide safer care and the number of people who are dying by suicide, we're going to lose over 50,000 people this year to suicide. And unfortunately, and those are just the ones we know about, including a physician a day. And so when we think about the amount of time that we spend on anticipatory guidance, flu, and some of these other pieces, we actually are going to be losing more people to suicide. And it's super important to really think about, as we're training and working with individuals who are in our teaching health centers, in our community health centers, who are learning, that it actually becomes part of the learning. I know when I started doing some of this work and we were, talking about depression screening, I would say, gosh, like maybe 1 to 2% of the people might answer yes to question 9 on the PHQ. And now we see much, much higher percentages. And I also know, as we've been going around the country talking to healthcare organizations, it's been about 3,100 people or more in about 31 states that we've talked to and done these suicide safer care presentations. And one of the things that has been most striking to me is no matter where we went in any residency program, there wasn't a single time when a resident or someone didn't come up to me and tell me a story about someone they lost to suicide in medical school or residency. And so I was wondering, Dr. Minton, you and I have talked about it a little bit, but having gone through medical school and residency and been a teacher and trainer, all of these years, I'm just wondering about, your thoughts, your losses, and what some things you think, we really should start to think about.
Thank you, Dr. Little. Yeah, I have the fun part of this presentation, just sharing from personal experience, so to say. But just as Dr. Little alluded to, I'm relatively young in my career, or new in my career, nearly a decade out of residency, but I can definitely think of many situations where colleagues, friends of mine, had suicidal thoughts, expressed them personally to me or a colleague, starting actually back in undergraduate times in college, and only more intensive and meaningful because of, I think, the shared burnout challenge and experience that we were living through in medical school and residency. And unfortunately, a colleague of mine in medical school died by suicide, and then a friend also during residency had a similar death. And when I think back over those tragic experiences, it was clear to me that there were warning signs beforehand that could have been seized, opportunities to engage with those in individuals in more meaningful, personal ways. And I think that begins with creating a culture of empathy and trust, and building into curriculum and training a recognition that this is something very real that impacts every one of us, that impacts the communities that we learn in, that we care for, that we are passionate about. And it begins again with a recognition of its presence, and it it begins with a process of confronting stigma, so that it is not such a taboo, foreign, dark topic, but something that is integral to what we do as learners and caretakers in the healthcare field. And then finally, I would just allude and sort of share with you all that as a person who's struggled with my own mental health challenges and suicidal thoughts at times, that experience only informs, I think, the work and questions that we're engaging with today, and it reminds me that we're not sort of safe from any of these experiences, and it gives me an incredible amount of compassion and empathy when I look to care for and ask about these questions with my patients, colleagues, and friends. So let me pause there and hand it back to you, Dr. Little.
Yeah, thank you for sharing. And I know, when I used to work with a family practice medicine residency program, I would actually always say that we need to talk to people coming into residency right away, give them information, give them the lifeline, let them know. And I was struck, I always thought that I knew the residents fairly well, or that they knew me. And I was struck one time, I did a training on depression screening and how you do it. And I just passed it out, and I, said people, fill it out and handing it back. And it was interesting to me how many people actually answered yes to question 9 in the room. And this was at rounds, right? This was at rounds. And someone came up to me afterwards and said, I didn't want to answer this because I didn't know who was going to see these, but I had actually planned to die by suicide a couple of months ago and called the Lifeline. And so it was interesting to me that this was someone right in our residency program that hadn't felt comfortable to come forward. And I think it's really important that as we think about residency and training programs and medical school, that we actually talk to people about suicide. I think it helps inform and keeps us safe, and also helps us in our patient care.
That's right.
So for certain. And I'm wondering, we also know it's important to really focus on healthcare settings. I think a lot of people who are in suicide prevention will say like something different really needs to happen in primary care. Most of the primary care providers we talked to nationally said, hey, yeah, like it's part of my role, like more than 95%, which didn't surprise me, because I've always known that about the primary care providers that I've worked with, that, I could see them thinking that suicide safer care was a part of their role. And we've learned a couple of things. We know that a lot of the people that die by suicide saw their primary care provider in the month of death. We also know that, interestingly, people who are disconnected from care, like they're not known to mental health, to dental, to primary care, they are not connected to care, they actually resurface in primary care the month of death for like 2 visits. We know that patients the month of death use the patient portal more and communicate with people more. So we're starting to learn a little bit more about what to look for. But what's interesting is that, during training, I know for me, I have a bachelor's in psychology and social work. I have a master's in social work and a doctorate in psychology. And never once did I get specialized training on really how to care for someone at risk for suicide. And I started my career working in an emergency room in North Central Bronx Hospital. Like, if there was anybody that probably needed some additional training in suicide care and risk assessment, it was me then. And when I think about some of the things that I did, but I'm wondering if you could just, touch on, when we think about the number of people that are going to die by suicide, like, did you get any training at any point along in your career?
Yeah. So very basic, simple training during residency, and I trained in internal medicine and primary care. Sort of knew the questions to ask, knew the questionnaires to be handed to the patient. Sort of knew what you should be looking for, but not much beyond that. And I think what was lacking was an emphasis on what to do once you have a positive screening, or once a patient shares or a client shares with you that they do have suicidal thoughts. Who should you include? What sort of resources are available to you in your practice setting? What members of the multidisciplinary care team should be included? And again, I think that sort of extends or grows out of a certain sense of fear and stigma. Again, feeling frozen, feeling that you do not necessarily have the tools as a primary care provider to really embrace and engage in an empathetic, meaningful, safe way with a patient when they are reaching out to you. So again, I feel in my training, which was only barely 10 years ago, the box was checked that I was aware of the PHQ-2, PHQ-9, aware of how to ask the right questions, but what was lacking was sort of that step and support around what you actually do when that positive screen comes back, when that client, friend, patient is sitting in front of you looking for help. And without that skill set, I think it becomes more of a challenge. It's scarier to sort of ask those questions. So I think that if there was more of an more training and more of an opportunity to be aware of what to do, I think it would have been a much more holistic, meaningful training experience.
Yeah. And I think it's helpful. Yeah, we're going to definitely talk about some storage statements and some things to be able to say. I also think it's helpful to really understand who's at risk.
That's right.
Interestingly, I hear from a lot of organizations about the seniors. When you think of almost 20% of the suicides being seniors, oftentimes I hear, well, of course they're, depressed, they're old, right? Or that most of the time people don't even get referred to behavioral health. Because, people think, well, there's not much they could do, or sort of they're old. And we know the greatest risk factor is losing a spouse or a partner, and then chronic illness. And, interestingly, my mother called me earlier in the week, and she said urgent, and I have a senior mother. And so, I responded pretty quickly. And she said, there was she has a rental, and there's been somebody that's been living in the rental for many, many years. And one of the things that he had a medical event and has been not feeling very well. He's not able to drive any longer. And the aide went in to go and see him and couldn't get into the home. So came and got my mother, and they went in, and he had tried to die by suicide. And so my mother, a senior herself, had to call, the ambulance. And he said when they, got him to the emergency room, I guess the pills didn't work. I tried, I was definitely trying to die by suicide. And, my mother was talking about it, and he had actually made some suicidal statements. And so, I think it was interesting that he or she kind of knows some of the work that I do. And she said, I just didn't think about what to do, right? And so I think it's important that we're really paying attention when, particularly seniors, oftentimes we dismiss, and many times it is medications for seniors. So really wanting to pay attention to some of those warning signs. A lot of times you say, well, I wish I could be with my partner, or I wish I could. And oftentimes those are dismissed. And I think we don't take them seriously around suicide. And so wanting to make sure that we're paying attention. I think one of the things most alarming to me is I'm shocked at how often I use pediatric and suicide in the same sentence now. The suicide rates rising in our 10 to 14-year-olds is just astronomical. And we know that NIMH actually says start screening your 10 and up sort of routinely. And someone gave me an interesting analogy the other day. When you think about this 8.9%, And you think if you walk down a high school hallway and about 35 students in every class, 35 students, about every third classroom, one of those students is going to try to die by suicide this year. And when you think about how many classrooms are in a high school hallway, and you really think about that, that actually is quite alarming, and how many of them actually seriously think about suicide. One of the things we know about youth suicide is that they're very lethal attempts. So jumping off buildings and hanging, and guns, sort of depending on geographic area, but certainly very concerning. And what we do know is that talking to a youth about suicide doesn't give them an idea. They already know about suicide. And I think it's really concerning for a lot of our pediatric providers to really start asking about suicide, but they know about suicide already. They likely have someone die by suicide. They certainly know about Kate Spade and other celebrities that have died by suicide. So really important to start to talk to youth and your pediatric patients, particularly around suicide. And a lot of the Joint Commission, HRSAs, some of those other folks now are really saying you have to put a process in place to be able to address your population at risk for suicide. And so really thinking about how are we caring for people at risk for suicide, and making sure that we're plugging some of the holes in our system. We've had patients that have died by suicide, that because the person picking up the phone didn't know they were at risk for suicide, so didn't know to ask anything different or to do anything different. We had someone die by suicide and they had canceled a couple of appointments. Nobody knew. There was no system in place to know that she was at risk for suicide, or to know that she had died by suicide. Nobody knew. There was nothing in place sort of to catch that. And it's really important to start to think about people that are at risk for suicide, and also different groups that are at risk. There was something in the news the other day about the rise in maternal suicides. And there's a gentleman, a husband of a woman who died by suicide a few days after giving birth to twins. And they had a plan for her, knowing that she had struggled with postpartum depression. But it really was very difficult to manage. And so really thinking about what are we doing to help catch people, to make sure that they don't fall through the cracks. And I encourage you to go on the Zero Suicide website, lots of free information and training that can help you organizationally, and also help you with your practice, to really think about some things that you can do, CMEs and CEU credits that are incredibly helpful. And I want to just sort of go back and ground us a little bit, and also talk very specifically about some of the things that Dr. Mitten said. So as we've been traveling around, we've kind of heard two things mostly. One is like, I don't know what to do, right? That I don't know what to say. I'm not sure what to do. And one of the things that we've learned is that there's one thing that saves lives, and it saves more lives than anything else. And anybody can do it, regardless of your licensure, or your background, or how long you've been in healthcare. And that's to give someone hope. Hope saves more lives than anything else. People who have hope don't die by suicide. And so anyone can give someone hope. Anyone has the knowledge or the ability to give someone hope. And one of the things we found, and this has come from teaching residents and training behavioral health providers, is to do what we call storage statements, to think about ahead of time, what might we say to someone who maybe told us for the very first time. And I know that I've had times in my life where I've told someone something, and that first couple of seconds has really like, should I have told them? Should I keep talking? And so really thinking about that for someone who's at risk for suicide, this might be the very first time they told someone. And so our initial response is going to be really important. So to think about some statements that we could actually use. So thank you for telling me you're thinking about suicide. And let's use the word suicide. Thank you for telling me you're thinking about suicide. We want to let someone know that their life is important to me. Your life is really important to me. You're important to us here at the center. You're important to us here at the practice. I know how much strength it took for you to tell me you're thinking about suicide. I have hope for you. And so maybe Dr. Minton, I don't know if you have thoughts about storage statements or what it would have meant to you to be able to say and to practice, you know what, I have 2 or 3 sentences that I can just say back to someone, you know, who's at risk.
Yeah, I mean, just as you alluded to, Dr. Little, I think sharing in that hope and messaging and signaling to them that you are there to hear them and to be a resource and a source of support. When you're having suicidal thoughts, I think it is an incredibly lonely state to be in, and knowing that there is a safe source to turn to, and that source is sort of there and giving you hope and is trusting, is an incredibly meaningful resource or act that you can do in the moment. So when I think back to my statements, it's just exactly as you alluded to, you know, thank you for sharing that. You know, it's really meaningful for me to hear that you're sharing this with me. I have hope for you. I am here as a resource for you. You know, do not hesitate to reach out when, you know, with further questions or with further needs. What people are looking for in that moment of crisis is that support, caring, thoughtful empathy. And I think that we undoubtedly have the time and training and resources to do that in the primary care setting. It only takes a few seconds to sort of respond in that way.
So, yeah, I think it's really important. And I would encourage you to practice the storage statements tonight when you're brushing your teeth or at a staff meeting. I think they're really helpful. And so the other thing that we heard when we were going around is, I don't have time, like busy primary care, you know, I really don't have time. And so oftentimes, and for some of you, maybe you might have heard me tell it, but I think it's just a really good example. You know, true story, my husband now knows I tell it. He was struck by lightning, lost a good chunk of his hearing. We went to the primary care provider, lovely medical assistant, height, weight, blood pressure, you know, checked us in, and then kind of left the room after taking his pressure. And so a couple minutes later, the primary care provider comes in, says, listen, takes his pressure again, says, listen, I'm really worried about you. Asked him some questions about medications and the day, and said, listen, I'm going to go see my other patients, and then I'm going to come back and we're going to figure out what to do. And so whether he had said yes to suicide or his pressure had been through the charts or off the charts, we do the same thing. We stop, we get some information, and we come up with a plan. Like, we do this all day long in primary care. It would be a beautiful day in primary care if somebody came in for just one thing, or the thing that they came in for was actually the most pressing thing. Like, we change gears all day long. Sometimes I, you know, can hear, like, think about being in visits and I don't even remember what the first thing was, right? And so really making sure, like, we do this already. And so having that system in place to say, here's our response and here's what we do, is actually incredibly important, and can and does happen in primary care. So we don't want to panic. We want to say, listen, here's our storage statements, right? Thank you for telling me you're thinking about suicide. And then we want to make sure that we're using the right language. And we want to start to keep a couple of things in mind. The first, and this is very different from how I was trained, many people who die by suicide don't have a mental illness at the time of death. And that's very different than, I think, what a lot of people think. These social determinants are huge in terms of risk for suicide. You know, the inability to get around, the economics, the finances, all of the the pieces. You know, we had a provider who told a story about, listen, I had this guy who was really worried about him, had a lot going on medically, and he died by suicide. I saw him, my team saw him, I talked to him. We never asked him about suicide, but he was having these health problems. He couldn't work as much. They were in trouble losing the house. His relationship was in trouble. And so he was absolutely at risk for suicide. And so really asking people, many of my patients who struggle like you are start to think about suicide. I'm wondering if you're thinking about suicide. Ask very directly, right? Also remember that many people who die by suicide don't have depression. Anxiety is a huge risk factor for suicide. And oftentimes we forget substance and alcohol use. Transition. So oftentimes we think about transitions as like coming out of a hospitalization, but really a geographic change for an adolescent, foster care, incarceration, substance abuse treatment, physical rehab. Those are all transitions, and they really put someone at risk for suicide. So really making sure that we're paying attention to those things. And we're paying attention to our population of patients at risk for suicide. Oftentimes, I go into organizations and I say, tell me about what you're doing for your diabetics. And people are so excited to tell me. We have this registry in our A1Cs, and we hired a diabetes educator, and now we're doing these eye exams with the ACU vision van and all these things, right? And then I say, well, tell me about how many people you have at risk for suicide. And like, nobody can answer that question. And so one of the things that it's really important, and you can start doing it today, like right after this webinar, you know, we live in a world where there's a code for everything. And so the codes for suicide thoughts and suicide attempts are actually already in your EMRs. They should be on your problem list so that you have it there as structured data. And also, if I'm covering for Julian and he has a patient at risk for suicide and it's on the problem list, I may make different decisions or ask different questions. So it becomes a real quality issue. And also, we spend a lot of time thinking about what we're going to do when we first identify a patient, but we don't really think about what happens when they come back. So if I come in to, you know, a center and I need to get some forms filled out and I answer yes to the suicide question, like lots of commotion, maybe I get referred out. And then I come back 3 weeks later, same forms. I see a different provider. It's not in my problem list. I come and go and nobody asks me if I'm safe. Nobody asks me if I got connected to care. And so that's a really important piece. I'm diabetic. And so when I go to the primary care provider, they do certain things because I'm diabetic. They ask me certain questions. They do certain things. But we don't have any of those systems in place for somebody at risk for suicide. And so it's really important to think about what do we want to do for people that are newly identified, and what do we want to do when that person at risk comes back to have a diabetes checkup. And so, Dr. Minton, I'm just wondering what some of your thoughts are, like, how hard would it be to do that in a primary care visitor? Or what are some like 1 or 2 questions you ask for other chronic illnesses that could be, you know, are you safe and do you have your safety plan for someone at risk for suicide?
Yeah, no, thank you for that question. I mean, I think, Dr. Little, you bring up the important point of how it's necessary to document and communicate what you learned with members of the multidisciplinary care team, especially as we transition to a care model where our colleagues are collectively caring for the patients and clients that we see, and being able to sort of share in that knowledge so that whether it's you or a colleague is seeing a patient client in the near future, that they're aware of this history and that they're able to check in and again create this culture context of trust and hopes that the patient client is able to and willing to sort of share if their symptoms are changing, if their suicidal thoughts are becoming more intense, so that across the board, wherever that patient is engaging with and interacting with care at your healthcare center, they feel safe, they feel able to sort of seek and turn for help. But once suicidal thoughts is on the problem list, once it's documented and shared, I think that it is the responsibility of whoever's seeing that patient client to check in, to ask that simple question. Do you feel safe? How are your thoughts? What is bringing you hope these days? What brings you back to clinic, so that they are aware that you are sending signals to them, that you care for them, that you're creating a culture of hope, and that you see that history of suicidal thoughts not as a challenge, but as a part of their medical presentation that you're going to address along with their hypertension or whatever their primary complaint is. Again, it's about destigmatizing the recognition and integrating mental health care into primary care, physical health practice within the primary care setting.
Thank you. Yeah, and I think it's, some is really just taking some of this on organizationally. I know many of you are screening with the PHQ-9. It is a lot of times the only time that people actually get asked about suicide with the question 9 on the PHQ-9. We do know that people that answer yes to question 9 are more likely to die by suicide. They're also more likely to die by homicide and other unintentional death, but they are more likely to die by suicide. So we really want to make sure. I also put the PHQ-A here for adolescents. And on the bottom, because of the prevalence of suicide risk in adolescents, many are putting what's called the ASQ, and I will go to that in a follow-up slide, on the bottom to be able to screen those ages 10 and up. So the ASQ is actually, I think, it's one of 2 evidence-based risk assessments. And there was a question in the chat about the younger ones. I actually find the ASQ better. It has a little bit more evidence behind it for children and adolescents. I like it better for a couple of reasons. One, because it's shorter, and it also has 2 attachments or 2 pieces. One is a script for nursing staff that people find helpful, and another is something for parents or guardians. And then paying particular attention to question 5, which are you having thoughts of suicide sort of right now, right? Are you having thoughts of killing yourself right now? So you're really getting at that risk. So people have asked a little bit about which tools. So this ASQ is actually one. It's evidence-based for all ages, but I actually like this one a little better for the children and adolescents that was in the chat. And so one of the things that we want to try to do is we do want to think about alternative levels of care. I worked in an emergency room for many years for people in crisis, and I can tell you I sent many people home. We know actually that many of the tools that are used in the emergency room could happen externally. And we also know that sending people to the emergency room who don't need to be there is actually worse for them. It can actually increase their risk. So we want to make sure that the people who need to get there, and that we have an understanding of how to actually assess risk in primary care like we do for many other settings. So I know that there was some discussion and that many of you are familiar with the Columbia scale or the CSSRS. There was a comment in the chat about using it for kids and adolescents. You can. It's actually sort of what's in your EMR and what's organizational preference. So what's interesting about the Columbia scale, or what I like, is that you can actually do different responses based on the color coding for your yellow, your orange, and your red patients. And so we'll talk a lot about what can happen in primary care for your yellow and orange patients. And what really is the difference is intent. I can think about suicide. I can know how I would die by suicide. So I've known many patients who said, oh yeah, I would go to this part on the bridge, or I would take this medication, or I would jump into that, this subway platform. But the issue was, do you intend to die by suicide, right? Have you started to work out or worked out the details of how to kill yourself? Do you intend to carry out this plan? So it's really the intent. I used to do something terrible, which was I used to say patient had, suicidal thoughts or ideation and had a plan, meaning knowing how they would die. And then I would send them to the emergency room. Like, that wasn't good care, right? Because it really is about intent. Do I intend to die by suicide? And so the patients who are red are people that need probably another set of eyes or maybe an alternate level of care. Whereas the yellow and orange patients, we can actually do quite a bit for them in our primary care. And so really understanding that intent puts someone at risk. And then thinking about protective factors. And I like to think about it like a seesaw or a teeter-totter, right? So I can have intent that actually really elevates my risk, but protective factors or reasons for living. And I ask people, because people have thought about not dying, right? They have thought about it. And so I say, what are the reasons you wouldn't die by suicide today? And I will hear my kids or my family, and I always reinforce, yes, absolutely, their children need their mom, right? Or pets. I can't tell you how many people I've had, if I leave my pet, they'll wind up in a shelter. Religion, job. A lot of healthcare workers will say my patients, very common to hear my patients. So the more reasons of living I have and the less intent, then the less at risk I am. The more intent I have and the less reasons for living, then the more at risk. And so really thinking of it like a seesaw and really understanding how that works is really helpful. And then doing, yes.
Sorry, just one quick question for you. I think a really great comment question in the chat. Given we've talked about how to document and communicate trend across the team, there was some concern around documenting a patient's suicidality when it comes to referral to post-acute care, or unfortunately when they're applying for health insurance. Could you comment at all around sort of how to balance those concerns with the importance of being able to communicate this risk and again create a culture where there's less stigma related to suicide?
Yeah, so I think a couple of things. One is there's the first level where people will often say, providers, I don't think my patients will want suicide on the problem list. And what I have often said to people is, listen, I just want to let you know that I documented our conversation on suicidal thoughts. And I want to make sure that anytime I talk to you or my team talks to you or I see you or my team sees you, we make sure you're safe, right? So that people really understand why we're doing that. Then I think the second piece is really concerns about liability. And I think it's important to really document the Columbia scale and lethal understanding protective factors. These are evidence-based practices, right? The Columbia scale, the ASQ are evidence-based practices. You're asking someone evidence-based information to assess their risk. You're documenting their protective factors or their lack thereof, right? And so if you're clear about what tools you're using and your documentation, that's some of the best that you can do. That's what's out there as really good care, right? And so that's really what it's about. And a lot of times people will say, well, it's really around insurance, but so many things now. I can't tell you, my husband had, and I'm probably going to screw this up, so Dr. Minton, you can fix me here if I get it wrong, but they accidentally put stage 3 kidney disease in my husband's chart. And like, he lost his life insurance and couldn't get life insurance. And it's like a whole big thing. And like, once it's there, it can't go away. So like we have a lot of these things now that happen where it affects your insurance, it affects these things. And I think we need to separate and say what's most important is that we care for you, that we put everything that we're addressing with you in your chart so that we can make sure that we're actively working with you on a care plan. We're making sure you're safe. We're making sure you get the best treatment. We're making sure our team is informed to care for you the very best way that we can. And I think that's inclusive of all of the diagnoses. And the minute we start to treat some of these behavioral health or suicide differently, I think we just reinforce. And I think that's a really important piece.
Thank you. Yeah.
And also, in terms of referrals to rehab, I spent a lot of time doing discharge planning, and there are things like suicide, fire setting, aggressive behaviors where, you have to really try to be realistic. But I do understand the difficulty of sometimes trying to get people the services that they need. But also saying we use the Columbia scale and they're not at risk. They didn't answer positive to intent, right? And so really being clear about some of those things. So thank you for pointing that question out, because we might not have gotten to it. So then what are we doing with our yellow and orange patients? So one of the things we know is 988 is up and running now. We know that 988 is evidence-based. We know it reduces suicidal thoughts and behaviors. We know that like 90% of the calls to the Lifeline are resolved on that call. They don't even need a follow-up. So I actually have people put it right in their phone. Sometimes they could call and I will go see other patients, right? So that it happens right there. Also, the Now Matters Now website. Now Matters Now is evidence-based. For those of you behavioral health primary care providers, has a really nice provider section on it as well. It's evidence-based, it's interactive. I used to give it to patients on a tablet to really go through. And so now we've given people the Lifeline, and Now Matters Now available to them 24 hours a day, evidence-based. That is incredibly helpful for your yellow and orange patients to be able to get that level of support and resources right there in the primary care visit. I also give them the Suicide is Different website for friends and family. That's often really helpful for them as well, and can be just something a little bit different. The other thing is that we do know risk can change a little bit. And so we now see a lot of suicide prevention really mirroring fire safety. So we have almost 300 people on this webinar. And if we were in one space and I asked everybody to raise their hand, what do you do if you catch on physical fire? I guarantee you every single one of you would raise your hand and you would say, stop, drop, and roll. Like, whenever we learned that, I don't remember when I learned it or who taught me, but I know that I've known it my entire life, right? And so one of the things, though, is nobody teaches us what to do if we catch on emotional fire, even though the likelihood that we're going to catch on emotional fire is low, right? We all need to know what to do. And turns out some of the same things work. So this is an emergency safety plan that's on the Now Matters Now website. And if I stop, drop, and roll, what am I not doing? I'm not dying by suicide. I splash cold water on my face, right? That actually is helpful physiologically to reduce and to reduce the suicidal thoughts and sort of break up the repetitive thinking. I look in someone's eyes. And so really thinking about, here is your emotional safety plan. You already know what to do if you catch on physical fire. Let me tell you what to do if you catch on emotional fire. And I think that's really helpful for people. And that analogy is helpful for people. I also think it's important to know about lethal means. So it's important to know how someone would die by suicide. The thing that we know about lethal means is that if I'm thinking about dying by suicide and using a gun, then one of the things is that if you can keep me safe from that gun, I'm not likely to switch means. I personally think it's because it gives someone hope. So we can talk to someone about lethal means and that it's temporary. This doesn't mean you're not going to be able to go hunting in the fall. It doesn't mean you won't be able to drive. all of my patients who talk to me about suicide, I really want to make sure they're safe. And if they're thinking about using a gun, then I really try to work with them so that they don't have access to the gun, right? So that this is what we do with all of our patients, and that we actually put it in the problem list, so that if I'm thinking about dying by suicide, suicide is on my problem list, and in the notes, it's medication or it's gun or, whatever my lethal means might happen to be. And so it's really important to start to think about that now. And to also ask, a lot of times we assume that it's the medication we're giving someone. So we need to ask, you've talked to me about dying by suicide, where would you get the medication, right? And so, well, when my grandmother passed away, my aunt saved all her medications, right? Talk now to your pharmacies about those individual pill packs. I like Amazon Pill Pack. Why do I like Amazon Pill Pack? Because it turns out it actually helps me remember my medication, which is a challenge. But also it's individual wrapped, right? If I have to open each wrapping, then I'm less likely to overdose. Also, maybe I don't have a gun permit, but I can hold ammunition, or I can hold the keys to a gun cabinet. And so it's really important to ask people, what would we need to do to keep you safe? If we were going to keep you from dying by suicide today and keep you safe from dying by suicide by gun, what would need to happen, or what would have happened? And a lot of people have said, well, my family locks up the guns. I would use the gun on the mantle, right? And so this way you're actually having that conversation, and you know what needs to happen in order to keep someone safe. So super important to actually ask people, what would need to happen? What would we need to do in order to keep you safe? The other piece that a lot of primary care organizations are doing is what's called caring contacts. And caring contacts are no ask. They are just, I used to send them when I worked in the emergency room for people that I was discharging. And I would just drop it in the mailbox. Hey, really glad we had a chance to meet. Hope this note finds you well. A lot of primary care providers will say, really glad we had a chance to meet today. Looking forward to seeing you next week, right? For people that got identified at risk for suicide, and maybe having it, just signed off and sending that off to them. And we know that actually has been helpful. It actually came out of Australia, where people were going out into the outback, right? They sent them that note and they reduced suicides. And so really important. It's certainly evidence is behind it. Here's some example caring messages. And I guess one of the things, just, to give us some time for Q&A the next couple of minutes, is just to sort of end with a story, and so that you all don't underestimate the hope that you can give someone, and how important your language and your responses are, and just how little it can sometimes take. I mentioned I used to send those caring notes, and I was in the grocery store with my daughter, and this woman walked up to me and she took the note out of her purse and said, thank you so much for sending this to me. I carry it with me. It's helpful. So just knowing that someone out there cared about her and had sent this note was actually so important to her. It gave her hope. And so all of the things that we talked about today, giving the resources, the lifeline, giving now matters now, asking questions, telling people, thank you for telling me you're thinking about suicide, and actually using the word suicide, especially with adolescents. We don't want to say this or that. We don't want to say, hurting yourself, because many adolescents might say, well, yes, but they may mean cutting versus dying by suicide. And so really important to say, use the word suicide to talk about suicide. Use your storage statements, your tools, and your resources to be able to give people hope. So I'm going to turn it to you, Dr. Mitten, just for a couple of closing remarks, and I'll go through some of the questions, and then we can try to get to some of them.
Yeah, thank you, Dr. Little. I mean, not much else to add, just to reiterate the meaning behind the caring message. Even easier to now do through the EHR or whichever form of communication portal you have with your patients. Again, it's creating hope, building trust, letting your patients and clients know that there's a resource that you can turn to, and really confronting a lot of the stigma around suicide. One question that's particularly meaningful that sticks out, Dr. Little, that I'm hoping that you could also comment on is thoughts on resources or how to support either parents of children who have expressed suicidal thoughts or members of a family that are caring for or love a person who has shared suicidal thoughts.
Yeah, and I think, working especially now, how difficult it is to think that your 10-year-old, or even younger, but that your 10-year-old is at risk for suicide. And so oftentimes I really try to normalize it and say, there's so much going on in the world these days. Unfortunately, many of our children are thinking about suicide, and we talk to many children your child's age every day about suicide. And so what I really want to do is I want to make sure you and your child both feel comfortable talking about suicide, because you may need to talk to one of their friends or someone in the community or someone else in your family. So I tend to broaden it a little bit. Like, I want you to be armed and I want you to ask directly, but I also soften it and try to normalize it a little bit so that we're going to do this, because then you can be resources for other people. I also find, particularly for adolescents, that I tend to use a Likert scale, like especially some of the adolescent boys, not always the most communicative, creatures on the planet. And so oftentimes I find it helpful. Like 10 is, I am on fire. I am on the absolute most risk for suicide I could possibly be. And, going down to 1. And so that they can then communicate to a parent or a guardian, I'm a 6. That's much easier than maybe trying to verbalize, that they're not feeling safe, or they can send a text, I'm a 6, right? And then you've worked with the family or the caregivers. If we're a 9 or a 10, we do this. If we're a 5 or a 6, maybe we go for a walk together, or we watch a movie, or we do something, or we pull out our safety plan, so that you can actually talk about it in terms of risk, and that you give people tools. And I think that's what we really wanted to do with all of you today, is we wanted to really give you tools. This is what I say. This is what I do in a primary care visit. This is how I really start to understand risk. And these are some things that I can help people in terms of reducing risk and giving them some evidence-based support. So thank you. There's some really super questions. There was a question in the chat too around the ability to support people, transgender community. I think it was specifically, sadly, the rates of suicide and risk in the transgender community is so high. There's a lot of really good sort of special resources. But honestly, I would really think about asking and talking about suicide pretty routinely, and making sure that people have resources and safety plans. Also talking a lot about healthcare providers in the chat as well. One of the things that was really interesting is no one looked at the suicide rates in nursing until a couple of years ago, and then found out that the suicide rates across nursing was incredibly high. So really important to support your staff and your employees and all of you, to make sure that you are asking the right questions and talking about suicide, and even making sure that the Lifeline numbers are up on bulletin boards, that it's out on safety plans, it's part of your organizational onboarding. A packet to your residents and your medical students might have information on suicide for themselves, for their patients. So I know we have 1 minute left. Rick, I'll turn it back over to you. Rick always is my good taskmaster and makes sure that I'm on time.
Thank you, Virna. And thank you, Dr. Little and Dr. Minton. This has been a fantastic presentation. And there's been such great engagement in the chat. And I did want to let everyone know that as a part of our next Suicide Safer Care series, we will be offering a dedicated office hours section to be able to continue the conversation. So I'm going to put the link in the chat, and I would encourage you to join us in August if you're interested in learning more about specific clinical pathways, creating sustainability, or addressing the risk of suicide in healthcare professionals. Also, as we conclude for today, I also just wanted to take a quick moment to remind you to please complete our evaluation and post survey. It's truly helpful to help us improve our trainings, and I'm going to put the link to the post survey in there as well. That being said, thank you so much again for your questions and for joining us today. And for those who we weren't able to get to the questions of, we'll definitely try to follow up by email afterwards. In the meantime, thank you so much, everyone. And thank you again, Dr. Minton and Dr. Little, for joining us today. And I hope everyone has a wonderful day.
Thank you, everyone. And thank you, Dr. Minton, and thank you, Rick.
Of course, thank you. All right, take care.
Bye-bye.